Do you think that using a diagnosis like borderline personality disorder is helpful for the patient, or do you think it's mixed? Do you think it depends on that patient's disposition and their personality, or do you think it's actually too stigmatizing? Or what's your experience been?
It's a great question. When we think of the concept of disease, historically, and I've written a little bit on this, right? Disease, dis-ease, disorder, something is out of order. And characteristically, or historically rather, the concept of disease is much more intricately tied to some combination of functional impairment and suffering than it is to known biological pathology, right? So there are a whole host of medical diseases that we have no problem calling diseases, and we have no idea what is going on in terms of the underlying pathophysiology. Migraine disorder is probably the best example. Lou Gehrig's disease, or ALS, is another disorder in which the underlying pathophysiology is unknown, right? So when it comes to psychiatric disorders, I have no problem referring to them as disorders or diseases because they cause some characteristic combination of functional impairment and suffering, often intense suffering. When it comes to borderline personality, of course, there have been other suggestions in terms of renaming the disorder. But I think because of the nature of the condition itself, whatever we rename it to will at some point carry a very similar type of social view or social stigma. Um, I think that you know while there are important discussions to be had around what is a disorder, what is a disease, and the like, I think borderline personality disorder um, is a condition that at this point in time has been very well researched. It certainly describes a unique set of patients or people who struggle in very similar ways. It was John Gunderson at Harvard, who operationalized the criteria for BPD in the 1970s, and it was added to the diagnostic manual, the APA's diagnostic manual, the DSM, in 1980. And so I think diagnosis is important. I think it very often gives the patient some idea of what is going on with me. And there are other people who suffer in ways that are very similar to the way I suffer, and there's a name for this. And there's a name for it. Not only is there a name for it, but there are treatments that can help me. And thus, I think this argument about pathologization is something that you encounter more frequently in the UK, but is also something that I think people, they don't have a good sense of diagnosis in medicine. Many medical conditions are are less than clear in terms of the etiology and the pathology of what's going on.
Yes, and we are more divided about it in the UK. And I know because I've been in both a psychotherapy training program, which is completely detached from medical psychiatry, and I've been in a psychiatric program. And the attitudes are very different. Now, I wouldn't say in the psychotherapy context it's totally dismissed, but it's certainly a lot more controversial and there's a lot more room for debate. My ultimate feelings about it is it depends a lot on how the diagnosis is
Mm.
delivered. I think the case can be made that diagnoses like borderline personality disorder are often delivered clumsily and badly by clinicians, sometimes, I'm sorry to say, even psychiatrists who don't have a sophisticated understanding of the condition. And they may be correct in terms of their diagnosis. The patient's symptoms may match that diagnosis. But in my experience, it's a diagnosis that needs to be delivered in a very skillful way. For example, all the things you mentioned, letting the patient know this is a way of understanding their whole collection of problems where it's not obvious that they're actually related to each other. It's an explanation that can help them find community and help them connect with other people. It can also help them understand their past, because you might come to understand you have this set of problems because you've had a series of adverse issues in your life, and in many ways these problems were originally coping strategies to deal with an early life environment that was very difficult. I think these are all important points, and they're points which I see not mentioned often enough in the diagnostic process. Often, for example, when a patient has come in after a suicide attempt with an overdose, and frustratingly often the attitude in inpatient in hospital settings can be, they have borderline personality disorder. This is not really a legitimate mental health condition like bipolar disorder or schizophrenia. And the irony is, it can lead them to feeling even more invalidated by the very people that are supposed to help them. So I'm definitely on board with you. I think diagnosis is important. The concern is, I see it often not being delivered skillfully enough, and also with enough humility, that even though this diagnosis has validity, there is kind of mystery, still mystery to the biology as well. Things along
I
those
think
lines.
that's beautifully said. And I think that that way of delivering the diagnosis, what ends up happening is the patient may avoid psychotherapy and they may avoid treatment for the rest of their lives because the diagnosis was delivered in such an inhumane and maybe hurtful way. And I think that does real damage, not only to patients but to the field as well. And I think that has to be mentioned. Yeah, I agree with all of that.